Okay, so welcome back to people viewing these sort of informational conversations about the recent COVID-19 pandemic. I am Adam Hertzberger. I'm in the biology department at Albright College, and this is my colleague, Dr. Josh Williamson. Josh, just do a quick intro, please.
Thanks, Adam. I'm the college physician here at Albright and director of the Gable Health Center. Um, and I'm glad to have another chance to talk with you on this, Adam.
It's been fun so far. I like doing things like this. I'm kind of a science nerd, if you will, right? So I like having these opportunities. But most important question, though, you haven't said anything yet since we've been chatting. Have you noticed something different about me?
Um, is it the haircut?
I got a quarantine buzz. Yeah, it was long overdue. I
Well,
borrowed a set of.
our viewers on this won't know this, but I am used to like I said, seeing you in a hat
That's
for our
right.
other meetings.
That's right. I like to dress down when I can, so I throw a ball cap on and, be casual. Um, but yeah, it was like a month or more overdue. And so I borrowed a set of clippers from a friend, and my wife went to town on it. All right. So what we thought we would focus on today is a little bit of some recent developments that have come out related to treatment, such as drug therapy and vaccines that are being developed. Okay. So before we go into that, Josh, I was hoping you might just review briefly the typical infection course, because that might help kind of ground us for further discussion.
Um, Sure. So, obviously there's more and more information coming out, so much in the news about asymptomatic carriers, but then also people that they're calling pre-symptomatic. So, they've been exposed. They have the virus in their system, but they haven't developed disease yet. And so the thought currently is on average about 5 days to develop symptoms, but that can range anywhere from 2 to 14 days, even longer. It's been described even longer in for some cases. Um, Unfortunately, the symptoms are often very mild in the beginning and variable. So very much flu-like symptoms, fever in a high percentage, usually dry cough initially, achiness, myalgias, sore throat. There's a lot about headache right now. A lot of patients starting off with just headache, diarrhea in a smaller percentage of patients. So kind of a wide array of possible symptoms. Oh, of course, we talked about this in one of our earlier episodes. The loss of smell and taste. So right there we mentioned just about and then rashes is the other thing. I was going to say we mentioned every body system, but yeah, that's about how it can affect you. Then after it's usually the second week that people start to really get sick if they're going to have severe disease, and so those are the patients that are ending up hospitalized. It's often the second week of symptoms. So a lot of patients are diagnosed and they're still having relatively mild disease, but then they develop that shortness of breath that is classic for more severe disease. Or I don't know if you can say classic here at this point, but and that's when they end up in the hospital and needing respiratory support, and things progress from there. The recovery for mild diseases is 1 to 2 weeks is what I've been seeing described mostly. For more severe disease, if you end up in the hospital or if you end up on a ventilator, the recovery time can be 3 weeks to over a month. That's just getting out of the hospital. There hasn't been too much described about the whole rehab process that people are going through, but I'm sure we'll have a lot more information about that in the coming months.
Right. There's a term, I believe it's called sequelae, right? The sort of the lingering after effects of the infection, right?
Yeah, that's an interesting thing that some of the doctors were describing in Italy, when this was just kicking off, and we were thinking that younger people were unaffected with this disease. Some of the doctors were describing they're not unaffected. They just made it out of the hospital, and they were having patients weeks into their rehab and still having trouble with shortness of breath, still having trouble with the severe achiness, and those lingering symptoms. So while they were considered recovered because they left the hospital, they were really far away from being recovered.
Sure. Okay, thank you. Thank you. And kind of as a follow-up from our previous episode, I think now might be a good time to kind of mention that, once we have more, sort of accessible and widespread testing, I think we'll have a better understanding of kind of the rates of infection and the amount of exposure that we currently have as sort of the population level. Because, so for example, Josh, like of known cases, about how many, like what percent on average are going to end up in the hospital?
I think the current number is about 15%.
About 15% will have some kind of more severe sort of presentation. Okay. And then, the numbers still kind of bear out that this is largely more dangerous than those that are, say, over 50, over 60. Like, what would you say?
I think the breakdown from most of the studies I've seen, they talk about over 75 for much higher risk of death. And I think that those numbers get into the teens, I think, at this point in the United States, as far as it can be fatal. It can be that fatal in that age group. That's why we're seeing so many nursing homes that are affected. Unfortunately, so many of the deaths are coming from nursing homes.
Right.
But then the overall fatality rate is much, much lower. And so once you get hospitalized, then you're obviously at higher risk for fatality. But I showed that we were in that meeting earlier this week, Adam, and I showed that slide that was basically the tip of the iceberg, and we really have no idea what's the bottom part of this iceberg, how big it is, because we really have no idea how many people are actually affected.
Exactly.
It will be interesting to see how, with the antibody tests, how many people show that they were exposed. We still have there's still a lot of questions as to whether or not a positive antibody test really means that you're immune to reinfection. There's a concern about the possibility of reinfection.
Exactly. Yeah, so that brings us back to the testing again. And so, yeah, so like what is the true sort of denominator, right? So you have the numerator of like severe cases / an actual fatal outcome. But then you have the denominator, like what is the total number of cases? Because right now, I think that the death rate is slightly inflated, at least in some groups, because we don't know the true denominator, right? In a lot of areas, the most severe cases or those that present with symptoms are the only ones being tested. And I have a hunch that the denominator is, I mean, I've read some actual like academic analysis of this, but my hunch is that it could be as much as 5 to even 10 times larger than what we know now. But we're not going to know that until we start to do some analysis and research. And there's going to be research on this for probably a decade to come. But for example, some tests that are coming on the market that are being developed, as you alluded to, Josh, are called antibody-based tests. And so just a brief sort of intro to that, when we get exposed to an infectious agent, whether it's a parasite, a fungus, bacterium, virus, our body will often mount an immune response. And one component of that immune response is to make antibodies. These are made by cells in the body called B cells. They develop in the bone marrow, and they circulate throughout our lymphatic system. And so if you go to the doctor, you get a physical, they palpate your your armpits and neck. They're trying to feel for enlarged lymph nodes, which basically are a major sort of organ of the lymphatic system. And when we get exposed to something, it kind of sends these B cells into a frenzy. And the B cells that have antibodies that are specific to that particular virus, they're very highly specific. They will essentially expand, divide, and create sort of like a small army of these things. And they secrete and release these antibodies that float around in our bloodstream, and they can go into our tissues and things like that. The first antibody made is called IgM. And so some of the testing will try to measure the levels of IgM, and that's the first antibody made to a infection, and it suggests that you've been infected recently. So if you have high IgM levels, it suggests that you've been infected, say, in the last 2 to 3 weeks. That IgM starts to come down, and it's replaced by another antibody that, and we're not going to go too much into the weeds on this, but essentially IgM is sort of a first responder, if you will, and then IgG, it gets higher affinity. It gets more specific. It's just basically a slightly better version of IgM. And so our body evolves from an IgM, which will then go down to IgG, which then comes up next. And so if you have a high IgG, but a low IgM to the virus, that suggests that you are sort of outside of that recent exposure window and are probably at least a month or two, and in some cases, potentially years. Now, that doesn't apply to this particular infection, COVID-19, but if anybody's been exposed to any kind of viral infection, or any infection for that matter, or had a vaccination, they might still have IgG floating around, and it could have been 10 years since you were exposed or had that vaccination, right? It's called immune memory, and it's very important to helping to fight an infection. The idea with immune memory is that you have that IgG already in you, and upon reinfection the second time, the idea is it will bind to it more quickly and go into action much more quickly than the first time around. It takes up to 2 to 3 weeks to develop that IgG the first infection, but that second infection, it's already there, and it goes into action within a matter of hours instead of weeks. Okay, so that's a little overview. So one of the things to kind of bring this back to COVID-19 is, well, if we can start to sample the general population, not just people who were hospitalized or even people who showed symptoms, just start sampling just random people to kind of get a sense of what is the rate of exposure in sort of in the general population. I think that's going to help us, and so they can measure IgM, they can measure IgG. Once again, IgM, recent exposure, higher levels of IgG tends to be you've been exposed sometime in the past, sometimes the distant past. Okay, Josh, did you want to add anything, or did you have anything you wanted to bring up related to that?
Yeah, just as far as the sampling, that's the tough part, is getting a representative sampling. One of the tests that came out, the company apparently recruited a couple thousand people in a town, I believe it was in Colorado, but they recruited, so they were all people from one area. There was low incidence of COVID in that area, and so the question is that test going to work as well somewhere else where there's potentially a lot more cases? NIH was recruiting patients, I guess it was 2 weeks now. I don't think they've put anything out from that yet, but 1,000 patients they were trying to get from more of a random sampling. Again, these are, you always run into that risk of selection bias where you're, the people that are going to volunteer, maybe
Right.
there's a reason why they volunteer, and it's a good thing, but they might not represent our entire population. And our population here in Reading is certainly different from New York City and Los Angeles and Seattle. And so it's sometimes hard to tell, even when you get a study that looks like it's pretty good, it may just not be generalizable to everybody.
Absolutely.
And that's, again, another one of the hard parts, all the stuff that came out of China initially, all the things that are coming out of the European countries, how much is it the same? How much is it different from what we're experiencing in the United States?
Right. Absolutely. So to kind of tie back to the immune system, we were talking in the first and second episodes, it does seem that when a patient starts to decompensate, when things start to go bad, there does seem to be this sort of, for lack of a better term, it's kind of a flashy term, the cytokine storm. But essentially, from what I can gather, it seems that the severe infections are related to kind of an overactive immune response to the virus. That it's typically so. For example, there was a study that I saw where they were doing the nasal swabs and testing using the PCR-based test. And for those of you that want a little more background on that, we discussed that in the previous episode, episode number 2. But there was a doctor, I believe it was, in the hospital, who had very, very mild symptoms, yet had extremely high levels of virus in their nasal passage. So just having high levels of virus doesn't necessarily mean that you're going to be symptomatic or have severe infection. Now, someone like that could be a spreader, okay? But in terms of their own personal medical experience, they're not presenting with any kind of, severe symptoms, but they have a lot of virus. And there's going to be a range, of people that have high or low virus and high or low levels of symptoms. But it does seem to me that it's largely an immune-mediated pathology that's causing a lot of these patients to have severe, like, pneumonia and respiratory distress, etc. So along those lines, to get to some of the drug therapy being tried. So you probably, some of you probably heard from the news about chloroquine or hydroxychloroquine. And from my understanding, and Josh, you can jump in, my understanding is that it's basically mixed. It's not a clear cut, yes, this helps. It's also not a clear cut, on the other side, God forbid, that actually does worse. I've seen some studies that's really no benefit. So can you add anything to that, Josh?
Well, early on in this, there was a lot of discussion about different treatments. And the thing that we always have to remember is that every medicine has some side effect, and every medicine has the potential to cause harm for somebody. And so we're always trying, in healthcare, we're always trying to weigh the risks versus benefits. And so it becomes very difficult when we have something like COVID-19 that's new. Of course, we want to do something, right, to try to help people. But you run the risk of doing harm when you're giving them any medication. Same thing with the vaccine. There's concerns there too, but we can get to that. So ideally, in Western medicine, we have years of experience with medications. We do well designed, well controlled studies to see what's helping, and that's it. It gets frustrating at times because there may be a study that shows that something works very well, and you think it's working very well, and we use those treatments for years sometimes for certain conditions, and then someone else will do a study that's maybe a little bit better, and it can turn everything on its head, and you realize that, oh, we thought we were doing people some good when we were doing that, but it really was potentially even making things worse for a lot of people. So you run into that, and we have the luxury of usually having years and thousands of patients in studies and knowing what really works and doesn't work. And with COVID-19, we're flying blind as far as treatments, as well as incidence of disease and course and everything else. So from now, we've had like we've talked about before, Adam. We've had coronaviruses. We've had viral infections that give similar disease in patients. So treatments have been used for other things like influenza, like SARS-CoV-1, and so So some of those treatments got thrown in right away to try to help patients with this. And then now, as we've gotten pretty far into the pandemic here, we're starting to tease out what's working better, what's what maybe looked like it was working initially, but maybe wasn't doing too much.
Right. And like you said, it's a lot all at once, and it's hard to set up a really well-controlled, well-designed study. Because, for example, a drug might work if given, say, in the first, say, 3 days, right? But it might not work in the second week. So it really depends on when it's given, the dose, and it's just, yeah, it's really hard to make heads or tails of a lot of this. So just to kind of wrap up, and those are very good points, so thank you. Just to kind of wrap up the hydroxychloroquine thing a little bit. So, I mean, and you can chime in. So when my understanding, so why was it tried? So my understanding, as someone who, thinks of the immune system, who teaches about it, I've only heard about it in the context, well, actually two contexts. One, in vitro, so like in cells growing in a plastic dish. If you add the drug to those cells and try to infect with a coronavirus, the virus will not enter the cells efficiently, and it won't start the replication process. So it's a block during the entry phase of infection. Once again, that's just in vitro. Whether or not the actual concentration of drug when you take it actually bathes your cells in that appropriate concentration in your body is unknown. So, but at least in vitro, it does inhibit coronavirus infection. The other piece is, my understanding is that some patients that have some inflammatory disorders or like an autoimmune disorder such as lupus are already prescribed hydroxychloroquine because it's sort of like a mild immune suppressant. And so to bring it back to the cytokine storm overactive immune system thing, I believe that is why some physicians have tried this, because of that connection to trying to dampen the immune response. Is that your understanding as well?
I think you're right. And, we talked before the show a little bit about Zithromax, and same story with Zithromax. That was something that was tried early on. Pretty early, it was found that didn't add a whole lot. And it seemed like the hydroxychloroquine probably was doing more. But both those medicines are known to have anti-inflammatory effects.
Okay.
So I think you're right. I think that was the thought early on, is that these anti-inflammatories that don't immune suppress as much as steroids.
Maybe like a steroid. Right? The steroid is going to be a lot more immune suppressive than like hydroxychloroquine, a little more mild, right?
Right.
Okay.
Right.
And so, just from a purely sort of a virological perspective, it's possible. And so I've been listening to some comments recently. I've been following some comments by, his name is Dr. Daniel Griffith. He works in some of the hospitals in New York City. So he's sort of like at that ground zero for COVID-19 in New York State. And he's an infectious disease doctor, and just sort of following his comments recently. And his comments make sense. So his idea is that if you give a steroid too early, it probably is detrimental, because you kind of need your immune response early to kind of help to dampen the viral replication. But then so if you give it too early, then the viral load is going to potentially be too high because your immune system is not acting as it should. So his thought is, maybe what's going to kind of come out of this is that dampening a little bit later. So maybe if you give a immune suppressant or a steroid in maybe that second week, when you're starting to decompensate and get more severe, maybe that's when it's going to work better. But once again, there needs to be trial designed to specifically test that. That's hypothesis at this point. So
and it just reminds me, as you're going through that, Adam, in sepsis in patients, steroids have been back and forth, and
mm-hmm.
and the timing has been looked at over and over again. So it kind of goes back to, we've had decades of trying to sort out when the best time to give a steroid. Is there a best time to give a steroid when it comes to sepsis? and here we are in a pandemic that's only been going on for maybe 6 months. Trying to figure that, we're trying to answer those types of questions that we haven't been able to get the answers for something that we deal with all the time in decades. So, yeah.
And just for, for the listener of this, or the viewer, I should say, sepsis, I mean, it's, I mean, a lot of things can cause sepsis, but, usually it's a bacterial infection in your bloodstream, and once again, your immune system just goes haywire because there's these, bacterial products just all over the place, and it just responds. The other piece is, okay, so the other thing that's been in the news, and we'll kind of wrap up today's episode talking about this, is remdesivir. And so that, interestingly, it's a mimic or an analog of a nucleotide. So what's a nucleotide, right? So I said before that this virus has an RNA containing genome, so RNA nucleotides. We have DNA containing genomes made up of DNA nucleotides. Basically, the virus has an enzyme that tries to copy the genome to make more copies, to make more virus. That's essentially what happens. And so the viral, and that's called the polymerase. So the virus has a RNA polymerase to make, to go from RNA genome to more RNA genomes to make more virus. And so this particular drug is trying to essentially gum up the works. The idea is that it's going to target that polymerase enzyme to inhibit the ability to replicate the RNA. So I mean, sort of hot off the press, I think even the Dr. Fauci mentioned this yesterday or the day before in the task force briefing, that some initial trials once again showed limited, if no effect. There's one trial out of China, and you can always, if you look at Gilead's stock, it goes up and down a lot based on the trial results that are coming out in the news, because that's the company that makes it. So once again, it might depend on when it's given. If it's given early, then perhaps it might limit virus replication. If given late, who knows, right? So anyway, timing might matter. But there was a recent study that came out. This, I think, was a multi-site, multi-center study, thousands of patients. Dr. Fauci kind of went over it a little bit. And it was given to a lot of severe patients, so given to people who really needed help. And on average, the length of the hospital stay, or was it, what was it, time in ICU or time on the ventilator? Do you remember, Josh?
I thought it was hospital stay, I think.
Hospital stay. So it went from 15 days to 11 days on average, and it was a significant reduction, when you run the statistics on it. So it wasn't like it went like you're cured the next day, unfortunately, but it did seem to have a positive effect. And once again, that's with this nucleotide mimic to try to stop the polymerase of the virus.
But unfortunately, the deaths were statistically similar.
Similar.
So while it did seem to help, some patients. It didn't. There's different outcomes we look at these, and obviously, death is a big one. We don't want that to happen to our patients ever. So it didn't actually change that outcome, but the hospital stay, it did change. So again, that kind of goes back to, was it just too late? Was it too late for some of these patients, unfortunately?
I think, I mean, this is just my opinion. I think a drug that targets virus replication, the earlier the better, is probably going to turn out to be the best option. Because, so for example, at that first test, or even that first symptom, like if there's enough of the drug, let's just say hypothetically there's enough of the drug to go around, if you have dry cough, a fever, maybe they should just be prescribed this immediately, assuming it has no side effects or toxicity. And of course, I'm talking as a researcher now, not as a medical doctor. But
that's what we do with our flu medicines.
Yeah.
Right, Adam? So those are indicated. Those are indicated within 48 hours of symptoms.
Or else it's not going to really have much of an effect, right? That's true. So like Tamiflu or some of these other ones. So the idea is, limit the amount of virus right away and allow the immune system kind of deal with the rest of it. But I think what might be happening is there's just too much virus, and that's too much of a trigger in certain people. And maybe it's an environmental background, maybe it's a genetic background, or both. But just some people are more prone to having these more severe inflammatory reactions. Okay, so we have 5 minutes left. So there's actually one more thing I just remembered. There's one more drug on the market. I can't remember like the trade name or the marketing name for it. but it's an IL-6 inhibitor. Do you happen to remember off the top of your head the name of it?
Now I'm blanking on
Yeah,
it too. Sorry.
it's really hard to say too. It's hard to say remdesivir.
I was glad you
Yeah.
tackled that.
Yeah. Once again, it deals with this immune issue. So IL-6, right? So IL-6 is one of these pro-inflammatory cytokines that often shows up after an infection. It helps to kind of ramp up. So like, for example, some inflammatory conditions or inflammation following an infection, you'll have levels of IL-6 go up. And it seems that from what I've seen in some of the early data release, that a lot of patients that decompensate have a spike in their IL-6 levels. And it can kind of, it basically just causes, it's one of these components potentially of this cytokine storm. And so there's a drug on the market that was developed for a completely unrelated disease. It's being tried as in sort of an immune suppressant now. And once again, there's been some mixed results, but there's been some results suggesting that it might help. That might be something, if given a little bit later in infection, might have more of a benefit because you're targeting that overactive immune response by blocking that IL-6. So it's actually an injected, it's actually an antibody. Some people out there that if you know somebody or even you yourself that use Humira or also Remicade, those are very popular, very famous. Those are also anti-inflammatory medications. Those are actually antibodies that you inject into your body, and those particular ones target a molecule called TNF alpha, which is another sort of inflammatory molecule. My understanding is when they look at blood levels of TNF for COVID patients, it's kind of variable, but it's not a huge spike as the IL-6 spike. So that's why they're trying anti-IL-6 therapy and not using something like Humira, because the TNF spike isn't quite as prominent, and so they thought it might not have as much of a therapeutic benefit. But it does seem that there potentially some promising results with the anti-IL-6 therapy. But once again, we need to have more data. Unfortunately, we're running out of, people are anxious to get back to the way things used to be. And so it's really hard because we're not finding, like, as of right now, like a sort of like a magic, serum or like a magic thing just to make it go away right away. The popular ones right now, hydroxychloroquine, or at least popular being discussed and tried, hydroxychloroquine, this nucleotide mimic, remdesivir, and then anti-IL-6. Those are the three that I see the most about. So did you want to comment at all, anything more, Josh, about that?
Well, we can just throw in there the plasma from patients that have recovered, convalescent plasma.
Right.
That goes
harder
right
to
along.
come by, unfortunately.
Right. And that goes right along with what you're saying, trying to get those good antibodies from people that have fought off the disease into people that need it.
Right. And that's like an ancient, not ancient, but that's more of like a historical, like tried and true. That, the problem is to get people to volunteer to do it and to get enough of that serum, because you basically have to do basically a big blood draw, and you put the red blood cells back into the person. You take their plasma, basically, like the clear liquid portion, isolate those antibodies, and then give them to people that are sick. And I think that has shown some benefit, but a person has to be far enough along in their infection to develop those good IgGs. And so it could take 4 to 6 weeks for somebody that's recovered to have those really good IgG molecules in their serum to then inject other people. And then you have to get enough of that to help enough people. So it probably could help people on a limited, like, site specific basis, like within one hospital, if you had enough recovered people come in for a blood donation. But it's not going to be something that's going to help kind of universally.
For sure.
Yeah, that's a good point. Thanks for bringing that up. I forgot about the plasma part. Great. Okay, so we both have a hard stop here. So I just wanted to thank people who are viewing this. Once again, if you have questions, you can find me on the biology department website. My email address is ahershberger@albright.edu, and be happy to field some questions. These are hopefully going to go up on the website very soon. Okay. Thank you, Josh, again for your time. Okay.
Thank you, Adam. It was a pleasure.
This is great. Yep. Thank you.